Dr. Glenn,
I
floor is
am.
yours.
Oh, thank you. Well, thank you all for having me back. I really enjoyed my time with everyone. This is the last session that I'm doing for you guys. Today's talk is about emotional and mental health needs for older Black Americans. And how I'm approaching this is that I'm going to provide some context as to why it's so important for our people. And then I'll branch out to just kind of mental and emotional health for older Americans in general. So next slide, please. So the objectives, I'm going to discuss some mental health statistics and explain why mental health needs are not being, I should say, met in Black communities. Also some resources specific for Black people, as well as mental health needs in general of older adults and ways that older adults can improve cognition and emotion. Next. So here are some sobering statistics. So about a quarter of Blacks seek mental health treatment compared to about 40% of white Americans. And we'll go into why this happens. People from the Black communities seeking mental health care, they're more likely to get that care from either the emergency room than going to a mental health specialist. The research suggests that adult Blacks are 20% more likely to have some serious mental health problems, such as major depressive disorder or a generalized anxiety disorder. And while we only comprise about 12% of the US population, we're often impacted, we often have many more significant negative impacts. For example, the Black community comprises about 40% of homeless individuals, as well as half of the prison population, and about 45% of our children in foster care. So you can kind of see how, we're not a huge part of the American population, but we comprise some areas that definitely are of concern. Next. So why are healthcare needs not being met? There was a study conducted by the Commonwealth Fund that looked at Black, and it's Latino, I'm sorry. I don't like the Latinx, but apparently Latinx people don't like it either. So Latino adults often experience racism. So there's provider bias and inequality of care. And so this can deter people from seeking mental health care. If you don't feel that people are going to listen to you, if you don't feel you're going to be given respect, you're going to be much less likely to go and engage in healthcare. And we know, specific to Black folks, we have historically been negatively affected by prejudice and discrimination in the healthcare system for hundreds of years. And unfortunately for us, many of these, we still have negative experiences. So, and then what I want to say about provider bias is that it's conscious and unconscious. So yes, it's pretty clear that the person's discriminating against you, versus also these microaggressions that we can experience when we do go into healthcare, or treatments not being offered to us and things like that. So when you have that provider bias going on, whether it's conscious or unconscious, it can lead to mistrust of mental health care professionals in general that are there to help you, and it can create a barrier for engaging in treatment. We know that racism has negative mental health impacts. Stress, anxiety, depression are common. We also know that in healthcare, when providers have bias and don't offer equal treatments to everyone, that it can lead to misdiagnoses and also adverse physical healthcare outcomes, which include greater morbidity and mortality from chronic diseases. So the Commonwealth Fund, as I had pointed out earlier, that had done this study, said that they had found that older adults that were of color reported feeling discriminated against when seeking healthcare disproportionately, and they were like twice as likely to report having a mental health diagnosis of depression or anxiety than those who had not been discriminated against. Next slide, please. Then the next issue that we have to deal with, we're thinking about mental and emotional health for our community members, has to do with we don't have, there's a shortage of culturally competent providers. So also there's a lack of coverage in terms of our healthcare covering mental health. So this is another significant contributing reason why our needs are not being met. And when I say culturally competent, so you don't only have to, it doesn't have to be that the provider has to be of your same background to provide you quality care, but they do have to have sensitivity and understand the context. It is critical that providers who want to provide mental health care to Black people and other folks of color, that they approach their treatment from a trauma-informed perspective, because Black people have sustained a lot of traumas. And I don't want to get in all in the weeds and what trauma-informed care means, but that's what I mean by culturally competent care. Our needs are different. They're important, but they're different. So we talk about equity and equality. We want to have equity in the healthcare, not giving everybody the same thing, giving them what they need. Also, there's things in terms of the community, and the faith community are very important to members of the Black community. So therefore, providers who are culturally competent have to be cognizant of this and utilize those resources in providing the support that people need. And then lastly, with regard to the shortage of qualified providers and being culturally competent, there are different theories and frameworks that providers use to guide them and kind of predict outcomes. And one of the things, if you think about the importance of the faith community and social supports and how we don't make decisions in isolations, as might be more common in other groups. The community of care model of treatment might work really well for many Black patients, in that families and friends and neighbors from a supportive network will all have different roles. Like some people might deliver meals, and other people might care for kids or pets to get somebody through a crisis. And a culturally competent provider would be cognizant of that model and enlist those people. Then, of course, you have your socioeconomic issues. So when we look at older adults in other high income countries, in general, their health care needs are met at much better rates than in the United States. So we have cost-related difficulties in getting health care. And then there's economic hardships. So we're moving in the right direction, but physical health care needs are seen as more important than mental health care needs by insurance companies. Not that that's true. So, I mean, and if you think about it, if you're, feeling down, but you don't know where your next meal is coming from, I mean, in the hierarchy of things, you've got to be able to nourish your body before you can be able to nourish your mind and mental health. So it logically speaking, a lot of times that can be an issue as well. Okay, next slide, please. Then there's cultural attitudes. So there are taboos and stigmas about mental health that can result in people not getting the care that they need. For many in the community, it can be challenging for people to discuss mental health, and because it might be perceived by others as, like, what are you talking about? We're strong, we can get through this. And people might feel like they don't want to seek care. Oftentimes too, that Black and Latino Americans are much more likely than whites to rely on religious institutions to help with mental health issues. That puts a tremendous burden on our clergy. And so it's important that they don't take the place of mental health professionals, but are seen as an adjunct to mental health. And then there was a study that showed that about over 90% of Black people indicate prayer is very important when coping with stress, compared with only about 67% of non-Hispanic whites. And then, once again, we have very good reasons as to why we don't trust the healthcare system historically, and also because of our own experiences with either lack of treatment or not being treated with respect if we're, it's very common. I'm doing kidney research and I talk with individuals and they share with me how, we're perceived as being able to have a higher pain tolerance. So sometimes we don't get the medications that we need. There were genetic markers used for kidney patients. It's changing now, but Black kidney patients that needed transplants were not getting them at the rates of other groups because of a particular genetic marker that they were looking at. So these things contribute to distrust and cultural attitudes being the way they are surrounding mental health. Next slide, please. So there's a couple of resources, books available on Amazon that aren't too expensive. This one, The Unapologetic Guide to Black Mental Health, is by Dr. Rita Walker, who's a psychologist and an expert in Black mental health. And she explores Black mental health in today's world and factors impacting mental health progress for African Americans and what needs to happen for Black people to heal from psychological distress, and finding community and reversing years of stigma and marginalization so they can get effective mental health care. So the book really highlights important information on the mental health crisis in the Black community. How do we deal with stigma? How to spot potential mental illness, as well as how to practice emotional wellness and how to get the best care possible in a system that's fraught with racial bias. So that's something to maybe consider to look at. Next slide, please. And then the other resource that I'm familiar with is this is called Black Mental Health Matters. And it's, we have lived experiences, like I said, of trauma. We do have experiences with depression and anxiety and a lot of other issues. And so this marriage and family therapist, Aaron Snyder, who wrote Black Health Matters, it spotlights the need to increase mental health awareness in the Black community through the use of real life stories that we can identify with and simple explanations of very complex psychological problems that impact our communities. So 2 relatively inexpensive reads. Next slide. Then I found some internet resources that I provided the links to with a brief overview of what they are. So BEAM is a training, my thing is training, movement, and building grant that's dedicated to healing and wellness and liberation of Black communities. Then you have the Boris Lawrence Henson Foundation that offers, they're almost like umbrellas to give you more resources. And then you have the National Alliance on Mental Illness. If you go to their homepage, it's specific for all mental illness, but then under the this particular link, it will take you right to Black African American and specific additional resources. So these are all resources that can be very helpful for us. All right, so when we just move kind of outward and look at mental health for older Americans in general, is question? Maybe.
Yes.
Oh.
Will those resources be made available to us so we can hand them out to our members?
Yeah, so I can go in and send a Word doc where they can access easily. Yeah,
Thank you.
Definitely.
We can make sure that the slides are made available, right, for folks that want them.
Well, how about those folks who don't have capability of opening the slide?
No, I mean the slides are made available as in printing them.
Okay, gotcha. Cool. All right.
Okay, next slide. So there's lots of triggers for depression in older Americans. So we know depression and anxiety, those are the 2 major things that we see. So when we think about health problems, we think about illness and disability. Pain is a huge problem and will cause depression. Cognitive decline can contribute to depression, as well as damage to body image due to surgeries and things like that, just general aging and sickness. So any kind of chronic illnesses, physical problems, disabilities, those kinds of things, those health problems are going to trigger depression in older adults in general. Then also loneliness and isolation. So living alone, a lot of older folks live alone. The social circle dwindles down as people pass on. Sometimes people have to relocate, for the convenience of their loved ones. They want to make sure that they're taken care of. They might move them closer, and you don't have that. Your social support is disrupted because you're moving. So that can cause people to experience depression. And another one that people don't think of a lot, but loss of driving. Loss of driving equals loss of independence for many people. So that can trigger depression in older Americans. A reduced sense of purpose. So when people retire, so many people are so closely identify their sense of purpose with their job. So when they retire, it can bring about a loss of identity or status or even self-confidence, and certainly even financial security once you're living on a fixed income. And this will hike up the rates of depression. Then also, along with reduced sense of purpose, if you have physical limitations on activities you used to enjoy, that can reduce your sense of purpose in life. Then there are fears, fear of dying, fear of death and dying, as well as financial problems or health issues. Those drive people to experience bouts of depression. Recent bereavements, so family members and friends or pets, your spouse, partners, these kinds of things will trigger depression. And certain medications, actually, there's a lot of medications that can trigger depression that have that as a side effect. So blood pressure medications like clonidine, beta blockers like Lopressor and Inderal, some of your high cholesterol drugs like Lipitor, Mevacor, tranquilizers or sedatives like Valium or Xanax or Halcion, GI meds that are used for ulcers like they don't use Zantac, we've taken that off the market, but like Tagamet. Some heart drugs, steroids can do it. So like cortisone or prednisone, if you're taking that for any kind of inflammation, and estrogens. So if you're on Primorin or anything for that, for menopause, postmenopause, and then some what we call anticholinergics, which are commonly used to treat GI. So there's a lot of things that could trigger someone who's older to experience depression. Next slide, please. So here are 10 facts about mental health and aging that we're going to go over. So number one, mental health problems are not a normal part of aging. So, we have as many as 1 in 5, so about 20% of adults experience mental health concerns, and it's not normal to it's not a normal part of the aging process. Like I said, the most common are anxiety and mood disorders. And when I say mood disorders, that would include depression. And about 6% of older adults actually have a depressive illness. So they're clinically diagnosed with some level of depression. The second fact about mental health and aging is mental health is as important as physical health, because good mental health is going to contribute overall to your general sense of well-being. And if you don't have good mental health, then you're going to have diminished functioning. Some people might engage in substance use. They're going to have, your quality of life is not going to be as good, probably not going to move around as much. And it actually can impact your healing from any physical illnesses. I think the things that I wanted to note about that, the most common, I talked about anxiety and mood disorders. Okay, next slide. Number 3, that healthy older adults can continue to thrive, grow, and enjoy life. So doing things like reading and walking and socializing are imperative to your mood and to your mental health and emotional health. And maintaining these social connections are extremely important. The fourth thing, mental health problems are a risk for older adults regardless of history. So regardless of fact, if you are going through life managing some type of a chronic mental illness or not, you can have you could be totally fine your whole life and then have a mental health or problem pop up late in life. And sometimes mental health will deteriorate in response to a issue like a stroke or Parkinson's disease. So these are neurological disorders where if you already have a mental health predisposition, maybe you were in your past were depressed or had anxiety or had bipolar or schizophrenia, and you experience a physical impact like a stroke or Parkinson's disease, or diabetes, or even some of the medications I talked about, that there's a number of medications that can trigger depression. That can put you at a little bit greater risk. So you can either have a history of mental or emotional health difficulties or not. You're still going to be at risk because of these other things that are going on. Next slide, please. Then suicide. We don't like to talk about this, but it is a risk among older adults, and we should be talking about it. Older adults have the highest rate of suicide in the country. People over 85 and over have the highest rate, and those 75 to 84 have the second highest rate. And the thing that's really scary is that older adults who attempt suicide are often successful at it. So if you're 65 and over, there's 1 suicide for every 4 attempts, compared to 1 suicide for every 20 attempts in all the other age groups. So this is another topic that's taboo, not just for older people, but as a nation in general, and we need to have discussions about it. Sometimes people just really feel they don't have any other options, and this is the option that they're choosing. So the more that we're aware of it, we can help people get the help that they need. 6, these are the symptoms that cause for some type of assistance with a healthcare professional. If you're having sadness lasting longer than a couple of weeks, if you're constantly worrying about money, family, and health, if you have consistent trouble sleeping or concentrating, and this is starting to impact your ability to perform your activities of daily living. So many of us, as we age, will have trouble sleeping. I myself, I have no shame. I'm 57 and I have problems sleeping, and it was, it has to do with, the loss of my spouse and my daughter. I just don't sleep through the night, but it doesn't interfere with my ability to be a professor. So think about it in the context is how is it impacting you to be able to do what you need to do on a daily basis? If you have frequent trouble remembering things or feeling confused in familiar places, and this is going for longer than 2 weeks, or if you're drinking more than 1 alcoholic drink a day, or taking more medication than prescribed because you think more is better, these are symptoms that call for you to meet with a healthcare professional. It can be your primary, and you discuss these with your primary, and they might need to refer you on for a specialist. Next slide. Number 7, older adults can be helped with the same success as younger people. So 80% of older adults that got some help from depression were able to recover. And so the treatment isn't always meds. Sometimes it's a combination of psychotherapy, so counseling and medication. Sometimes it ideally shouldn't only be medication. It should be that the person is getting some counseling and they're taking medication if medication is warranted. Number 8, our health system is not adequately helping older people with mental disorders. Medicare does cover 80% of physical health problems, but only about 50% of mental health problems. So this is a barrier for many people. So we have an awareness of that. And researchers estimate that up to 63% of older adults with a mental disorder get the services that they need. And 75% of those who commit suicide actually did visit a primary care physician within a month of their suicide. So these are some sobering reminders that we have a long ways to go, but the COVID crisis has really triggered a lot of research generally in the area, and it's highlighted the disparities among not only racial groups and ethnic groups, but age groups. So hopefully this will be changing. All right, next slide. So when we just specifically spotlight on depression, so risk factors for late onset depression are things like widowhood, any physical illnesses someone has, people who have low educational attainments. We're talking less than high school, they're at a greater risk for depression. If there's some impaired functional status, so if they're not able to complete their activities of daily living, get dressing, toileting, that will put them for risk of depression, as well as heavy alcohol consumption. The positive thing with depression, it's one of the more successfully treated illnesses in mental health. And so you can see dramatic improvement with counseling and in some cases medication. Next slide. Symptoms that we would see are sadness or feelings of despair, unexplained. And I want to back up. So I do want to say that depressed older adults, sometimes they don't necessarily feel sad. They're just feeling like this is probably like a part of aging. So I want to highlight that because some of these other symptoms are going to be more important to pay attention to, because if a person's not saying they feel sad, you might not recognize that they are experiencing depression and maybe will need to be evaluated for depression. So you can see sadness or feelings of despair, but not always. Unexplained aches and pains, a loss of interest in socializing, people not wanting to get together, not doing their favorite hobbies, weight loss, feeling hopeless or helpless is often how it will manifest as opposed to sadness. Just a lower energy. Definitely more complaints of physical kind of complaints like arthritic pain or worsening headaches. That you'll see that a lot more in older adults. Sleep disturbances, loss of self-worth, slowed movement or speech, increased use of substances. Sometimes people become very fixated on death and might have thoughts of suicide, memory problems, and then neglecting of personal care. Now, what I do want to say is one of the things as a healthcare provider, we can't ever just jump right into mental health in terms of, we have to make sure that there's not some kind of physical change that has gone on that might have led to some of these symptoms. So for someone, for example, who has had slowed movement or speech, we're not going to just jump right to like, oh, that person might be having depression. We have to make sure like what is going on, that their movement has changed or their speech has changed, that they had a stroke, a TIA, or they have some kind of neurological problem. So please just be mindful that healthcare providers will absolutely want to rule out any kind of physical contributions to a person's situation before moving on to emotional and mental health. Next slide. So oftentimes, because there are so many losses we experience as we age, people are not really sure, is it grief or is it depression? And so I wanted to just compare and contrast the two. Loss is painful, whether it's loss of independence or mobility or your career. So when we think about losses, think about it kind of globally. So you can grieve losses of things like that. And grief over loss is normal and it's healthy, even if you're sad for like a long time. So with grief, it's like a roller coaster. You're going to have good days, you're going to have bad days. Where depression is our feelings of constant emptiness and despair. During grief, even when you're grieving, you're still going to have some moments of pleasure or happiness. But with depression, while there's no timetable for grief, everybody grieves at their own time. People, they could take, you don't get over the loss of a loved one. And so those acute phases of grief for some people might last, a year. Some people it might be 5 years. So there's no timetable. But if it doesn't ease over time, or all joy from life is lost, then maybe that person is dealing with something different. So I explain to people, like, when you lose someone early, it's like this sharp stabbing kind of pain that you have. And then over time, the pain is just there in the background. And then there might be trigger moments where you might have twinges of pain, whether it is a death date or a birth date, or, you're reliving those weeks or days or months before your loved one passed, if they had a chronic illness. So, but it's, if the person if it's not easing up, there's something else going on. And if there is no sign of joy, it could be depression, it could be something else. But this is how you can kind of get a gauge on, you know, someone you care about, if they're dealing with grief, or you're like, yeah, I'm not really sure. I know there's no timetable for grief, but this seems to be, I'm concerned about this. Next slide. And then just looking briefly on anxiety, which is the other end of the spectrum, if you will. Sometimes anxiety and depression can be together, particularly with older adults. Maybe an older adult's diagnosed with major depression, but they also meet criteria for anxiety. It's not really well understood when it occurs later in life. And it may be underreported because older folks are more likely to kind of focus on like physical symptoms and not necessarily like, you know, oh, it's like more emotional type of symptoms when they're trying to express what they're feeling. So not really well understood, can come together with depression, but there are medications that can address it, and certainly counseling would help with that. Okay, next slide. So what are things that we can do to improve our mental health? Well, we covered, you know, 2 sessions on that. You know, we talked about engaging in, you know, playing mind type games, keeping yourself sharp with those kinds of things, and being physical. So we already had 2 wellness sessions on that. And it did address, you know, staying connected with friends. So keeping in touch with important people in our lives, picking up a new hobby, if you know, staying with a hobby you have or picking up a new one. Hobbies help to increase neuroplasticity of the brain. So this is where the nerve cells connect or reconnect, and changing the brain's structure and function. So when you're stimulated through and engaging in activities that increase neuroplasticity, that helps with a mental health, emotional health, cognition. Because it's strengthening these neural pathways. And so new connections actually can be established, and you'll have and it's really good for your cognitive state. So that's really important. Volunteering helps people to stay active and feeling vibrant, feeling a sense of purpose. Also, you can make new friends when you're volunteering. And then caring for a pet. So according to the CDC, there's tons of studies that show that the bond between humans and pets can increase their fitness, lower stress, bring happiness, decrease blood pressure, decrease feelings of loneliness, increase opportunities for socialization, particularly if you have a dog and you're out walking it. But if you are unable or unwilling to have a pet, but you enjoy pets, you can volunteer at an animal shelter, which is a good way to connect with a pet, with animals, and help them in that way. So you don't have to, you know, owning a pet is a huge responsibility, and some places where we live don't allow for pets, or it costs extra money to have pets. It costs extra money to feed the pets and take them to the vet. So you can certainly get your pet fix if you would like to have access to pets by volunteering. And I think that is it. Yes, that's just my references. So I went through a lot of material. Any questions or concerns? I thank you for all of your attention. It's a quiet group today.
Miss Ritchie, I believe you're talking on mute.
Okay, I've corrected that, Kim. Okay, thank you. Okay, when you discuss the symptoms of depression,
Yes.
okay, under those in those symptoms that were listed, do any of those relate to dementia?
Oh, that's an excellent question. There can be a little bit of overlap there, you know, when people getting more forgetful, things like that. So that's why it's really important. Like I said, you know, a lot of times they'll start out with your primary care provider, so they can make sure that there is not any physical reason for the person experiencing the symptom, and then being referred to the next days. So if you start out with your primary care provider, and they have been able to run some tests, and for some dementia, I mean, we're still working on it. We're coming along in terms of being able to identify some markers. You know, sometimes we don't have a solid diagnosis, if you will, in terms of the actual cause. Because remember, dementia is like an umbrella term. There are different causes of dementia. But make sure, engage with your provider if they're not comfortable in terms of being able to manage you with regard to your mental health. They should be able to definitely refer you.
I also found it interesting with the statistics on the suicide for older adults.
Yeah,
So
right.
when I heard that, I'm like, oh, okay.
Yeah.
Yeah, go ahead, I'm sorry.
And oftentimes when people pass by suicide, we don't really know, like you'll read this, you don't know how they passed away, but when we look, the CDC has access to obviously statistics, and you can see, when they have the reports when people have committed suicide. But it is, when I was researching for this talk, I was like, oh my gosh. I mean, I knew it was significant, but I didn't realize it was that significant myself. So I learned a lot too when I was researching for this, and it's frightening. Yeah.
If you have questions, please feel free to unmute. If you're on the phone and you need to unmute, you can hit *6 and that will unmute you. Feel free to ask your questions. This is more of a your opinion question. So what do you see as the role of the community, the church, community organizations in supporting or bringing awareness to just what you've brought to us? Because I feel like Ms. Ritchie, you kind of get a sense of some of this, but it's what you think sometimes, not what you actually know.
Yeah, that's an excellent question. So I think the community and the church just you can't feel like taking all that in, right? Like, it's like, obviously our clergy have experience in wise counsel, but sometimes it's just kind of over. Like they need to be viewed more as a support. So when you have and I'm sure people in the community, whether it's the faith community or the community in general, you see people that are in these different places, having conversations with them and encouraging them to follow up and be evaluated, because we are hesitant to engage with mental and emotional health. There are a lot of resources available. That's like I said, I wanted to share with you all resources that you can share with people that might be struggling, or know people that might be struggling. But I definitely think it's a two-way street. I think healthcare providers too, once again, it goes back to having culturally competent providers, need to work hand in hand with the Black community and with faith leaders to be able to provide a safety net, right? So that people feel comfortable both ways sharing information. But it's still pretty I'm very pleased in that we have a lot of high visibility people that are bringing to attention, like Taraji P. Henson, for example, bringing attention to the fact that we need to take care of ourselves mentally and emotionally. So I think the more we see that, the more we're going to see some of these barriers kind of fall. And the more that we recognize that we need to give people what they need. So what works really well in one community maybe it's not going to work so well in another community, and we need our providers to know that and how to guide people appropriately.
Okay, I'm going to be the one today, huh? So as someone who has been a caregiver for an older adult and continues to be, how do we go about having competent conversations, or interjecting ourselves to initiate competent conversation with providers of the people that we help take care of? Because I think that's a big barrier too, right? Is that people are independent and we can't always, it's hard to nudge folks in a direction.
Yeah, so I mean that is the slippery slope, right? When you're taking care of an older person, let's say it's a parent or a spouse, and they are still adults, and I am a big fan of patience and just reintroducing things in different ways. So, and in terms of talking with providers, I think it's important to show, when you're going to a provider, show them that you've done homework on your end in terms of, I have this love-hate relationship with my profession, or the healthcare profession in general, because we have not done a good job empowering people to become consumers, but we expect you to be a consumer when you come to us, right? So, how it was historically, you come to a provider and we'd have all the answers. We'd tell you what to do. That's not the case in today's healthcare world. So you need to come prepared. So in engaging in some of these resources I've shared with you, if you have a loved one that you're concerned about that could be having depression or anxiety or both or something else, knowing that, look, these are the things I'm observing. These are the things I've read about that could be helpful. I need you to guide me to where I can get the best help for this person. And then when you're having the conversation with the person, just have slow introductions. It's just best to always present objective information and talk about it in terms of what you're observing. Then it's much harder to argue with that, other than I love you and I care about you and I want this for you. Just stand back and say, I'm really concerned because I've been seeing that you haven't been eating quite as much, and it seems like you when I see you, you know I enjoyed when you had that face full of makeup, and I'm seeing that now you're not putting on as much makeup. Can you tell me what's going on? Is there something I can do for you? Those kind of tangible things, because someone who is actually in a depression or in a mental health state, they're not going to necessarily it's very gradual, right? So it's not like all of a sudden they wake up one day and they're just like super sad. It's like they'll stop, maybe they'll go from maybe not getting their nails done every 2 weeks to next thing you know, they're not brushing their teeth. And next thing you know, they're not doing their hair. And next thing you know, they're not changing their clothes. It's that kind of thing. And so trying to discern, is it, over what time of a time period has this happened? Has it happened, rather quickly, which might signal that this might be something more acute like a depression, versus this has been happening over a period of months where maybe it's something related to dementia or some kind of cognitive decline. That's not for you to decide. It's just, that's a piece of information that you could provide to a provider. Like, this has been going on over 6 months versus I've really noticed this in the last month. And then think about those triggering events that could, somebody that was diagnosed with something recently, or they lost a spouse recently, or they lost their job. Sometimes those triggers will cause you to see symptoms in someone, and it's a little bit easier to kind of see that this is an acute thing versus it's something related to a cognitive decline.
That to me is a good point, because I have experience, like relatives who think they going to the doctor, telling the doctor what they should prescribe for them and what they're going to do and not do, and think they have something like a thing over the doctor. So then the doctors change, and then you get this new doctor, and the doctor's, I'm not listening to you. I'm the doctor here. You see what I'm saying? And to me, that because they're trying to avoid what I think is good advice from the doctor. But like you said, you can't tell people what to do. You know what I'm saying?
Right.
You can offer suggestions and say this and say that, but you can say, listen to your doctor. The doctor might be helping you more than you think. But they think that they can go tell the doctor, I'm coming back in 3 months. The doctor says, oh no, you're coming back when I tell you. And I think that's, I think that's good advice. You can't determine, it's good for you to tell the doctor what is, what you're going through, you know what I'm saying? And it's good to have a doctor that will listen to you,
Yeah, that's a key point that you're pointing out, Ms. Ritchie, because you have to find somebody that works with you, your partner in this. And we know as healthcare providers, people are much more successful and have better health outcomes when they have some kind of buy-in. When I'm meeting with patients, I always listen to what they have to say. And while I might be constrained by the amount of time that I have with the person, I will either, I'll circle back. I'll be like, I'll call that person, or I'll encourage them, is it possible for you to make an appointment again so we can have like a part 2, or I'll try to address the immediate needs. So, your health and your loved one's health better than anybody else. And so I like to listen, because you have those day-to-day nuances that I'm going to miss, right? And I might want to have one approach, and it might work better if we work. It definitely would work better if we work together. So I encourage people to, if possible, having somebody with them when they do visit their provider, because sometimes they'll think of a really good question you might not have thought of. It's very anxiety producing for many people to go into the office. They have their list of things, and then they might get sidetracked, or the provider comes in kind of flustered, and you can clearly tell that they don't have a lot of time for you that day, but you're important. That time that's carved out for you is your time, and they need to respect that. So having somebody with you, making a list of questions, asking about websites you're not really sure about. You'll notice that generally the websites I try to provide links to, they're either a .org or a .edu or a .gov. Those are the sites that are safe sites, if you will, because anybody can set up a website. People get their information from a .com, and they can look really professional and snazzy, and people twist things the way they want to twist them. So it's really important you can bring that in. And I think as providers, we need to be better at offering people sites as well. So I definitely learn from my patients, and I enjoy when they bring in information, and I enjoy when they challenge me, because it helps me learn and recognize what's important. And I just put that in my little cap. So let's get in the consumer mindset.
Right.
So my next question takes us out of the healthcare market and into the community. We are a community of faith. We are not practitioners by any stretch of the imagination, but we have an implied responsibility to care for one another. Right. And so I think, and we all know, I think in the church, probably more than other places, we encounter a plethora of interesting people with interesting things happening with them. And we all experience life. And we're trying to experience life in a way that's different than other spaces. This is not work. You know what I mean? It's not necessarily our social group of friends either. It can be, but not necessarily. So how do we create, what kinds of things can we do to create a culture, right, that encourages each other or encourages people either with some sort of emotional concern at the time, or just being a supportive body of people? Like, what are the cultural things that we would need to kind of take on to be a healthy organization in that way?
That's an excellent question. I think one of the things that would be important, and you might have done this already, is that you have the people in the faith community have established ground rules for discussions around the topics, in terms of where people feel like it's a safe space. So we have assumptions that being in a faith community is a safe space, but sometimes, I've been in situations that's not always the case. So, and to get the buy-in from people, is they need to have a hand in developing those ground rules. And that basically, everybody's opinions are to be respected, not, and argue not arguing at not getting mad at the person. Like if they say something or they're offering some advice, but look at the situation, trying to keep things very objective. So having just like a set of ground rules where people can have discussions, and then have resources for people where they could go if they feel like they need something beyond the faith community. And I'm sure that, I'd love to hear in terms of from the pastor, how clergy are prepared to address situations like this with their congregations and the community at large.
As a pastor, I can say unequivocally, we're not prepared. Okay. Our typical seminary training even post-seminary training, it's always about referrals. You know, there's some things that we can pinpoint based on lived experiences, but educationally, I, for one, have no training in dealing with mental health. Okay? I speak for myself.
So I think even I think even people having an awareness that, you know, that the guidance is from a spiritual aspect, and then they are not trained to be able to handle it from a medical or healthcare psychological aspect is important, because there are assumptions among people. If that's where people are going, for many people, they're going to their clergy, and the clergy are not in the position to be able to offer what they might need beyond spiritual guidance. People need to be aware of that, and that needs to be in clearly created ground rules.
Mhm. Mhm.
So, and I think that it's important to note that's going to be too minister specific, right? Because a lot of ministers do psychological tracks,
Yes, it definitely would be.
and have
Yep.
concentrations in counseling. So, I
Yep.
mean, and I think that's what makes the Methodist, well, that's what makes our situation hard, right?
Yes.
Because we don't have consistency with that. That can change
Well,
every year.
and that's what is nice
You
with
know?
if you have ground rules, right? They can fluctuate based on who's leading the church, so that, you know, you would need to revisit them whenever there's a change in leadership, and with the input of everyone, you know, change them around, because yes, absolutely. So I think that would be like a first step, and then like I said, utilizing the resources that are available. Yep.